Hey, good morning, everyone. We'll go ahead and get started. And greetings from Vancouver this morning. Thank you all for joining us. It's my pleasure to introduce Anjali Satoskar, who's going to be talking to us today about IgA and infection-related glomerulonephritis.
Thanks, Mei Lin. Thanks for the kind introduction. Let me share the screen. Thanks to hello everyone, and thanks to GlomCon for inviting me again. I enjoy giving lectures on this truly international platform. I actually changed the title of my topic a little bit. Initially, the topic was Staphylococcus infection, SAGN or IRGN, but in this lecture at least, my intention is not to go through the detailed description of all the different types of IRGNs, because that has been discussed before. There are good chapters on it and everything. What I want to really talk about today is the difficult cases that pose a diagnostic conundrum, and which makes it difficult for us to differentiate a true IRGN from its very close mimics, which we commonly see, that is IgA nephropathy and ANCA-associated GNs. There could be others like drug-induced GN, sometimes even lupus, but today I'll just focus on the differentiating IgN from IgA and ANCA. So with that, I'll begin. It's a slightly long lecture. I just have two introductory slides here. When I think of or when I talk about infection-associated GN, I usually conceptualize it under three heads. Our conventional post-streptococcal GN on one hand, on one side of the spectrum, and the other side of the spectrum is this ongoing or active infection associated glomerulonephritis, like a concomitant infection and GN. And there is a third category in the middle, which is definitely overlapping. It is also an ongoing infection-associated GN, but usually the infection is going on for a while. It's chronic infection, typically seen in the subacute bacterial endocarditis-associated GN, or shunt nephritis, or indwelling central venous catheter infections. The bacteriology is a little different. They're low virulence bacteria compared to MRSA. They're maybe part of your oral flora, skin flora, even Bartonella, Coxiella, Chlamydia, Hayseck. Many of these are very fastidious bacteria. Cultures are usually negative. Serologies are needed, something to keep in mind. So as you go from left to right, what you see is the latent period, the infection-free latent period disappears. So on this side of the spectrum, it is the infection is still active. The treatment of the infection takes center stage. And without treating the infection, the GN is very unlikely to resolve. And it's a very good idea not to label all of these under the common head of post-infectious, because they are not. The histology may not necessarily be very different in these three groups. There's definitely a lot of overlap. However, the management approach is very, very different. That's why it's important to differentiate them. The demography is very different. You see older, you can see this is from a pediatric predominant population to a more older adult population. It could be old adults or young adults. There's a spectrum. Risk factors are different. You see a broad spectrum of infections ranging from endocarditis, bacteremia, osteomyelitis, septic arthritis, and so on. Infections are often occult, difficult to find. Clinical presentations of the patients can be very non-specific. Infection may be least expected. In the biopsy, glomerular IgA staining is a very unique feature in staph-associated GN, which was not seen in post-strep, and of course, along with C3. And that is why it can look like IgA nephropathy. That is why this topic has become the topic of so many papers and reviews, because it poses a differential diagnostic difficulty with IgA nephropathy, which is one of the most common GNs all across the world. You also see the glomerular morphology itself can show a very broad spectrum, right? From mild mesangial hypercellularity to diffuse exudative proliferative lesions and crescents. Subepithelial humps, which are so pathognomonic in post-strep, are seen very less commonly or less frequently in staph-associated or other ongoing IRGNs. Just maybe about 10 to 15% of the cases will show humps. If they're there, they're useful, but if they're not, you cannot exclude the diagnosis.